welcome everybody to this Lunch and Learn webinar looking at the Making Every Contact Count for Mental Health training programme that we have commissioned within the Northwest of England PPN and Health Education England in collaboration with Psychological Professions Network. So I'm delighted to have been working with the Royal Society of Public Health for us to lead on the development and the delivery of this programme, a very important programme that really sprung from the long-term plan and the mental health target to significantly expand the mental health workforce, and I'm sure that this is a topic and an area of expansion that a lot of people, not just within our region but across the regions, have been really working hard on. Part of our conversation about that expansion led us to have a think about, well, who are the mental health workforce and whose business is mental health? And as part of that conversation, we looked across the workforce and really identified that really mental health is everybody's business, and that the frontline workforce that might be working in lots of parts of health and care could really benefit from being upskilled in terms of developing confidence and competence to meaningfully integrate mental health, conversations about mental health and well-being into everyday consultations and conversations. So today's presentation is really giving us an overview of the development of that programme, and 2 years on, the outputs and the evaluation that has sprung from that really gives us a very strong grounding for evidence that working in this way can have great benefits for the system. So I'm going to hand over to Kieran in order to talk a little bit about the background to the project. Whilst Kieran's talking and sort of giving us a little bit more context, if I could ask those of you that are in the room with us, if you're able to pop into the chat box your name, your job title and the organisation that you're working with, and if there's anything that you can tell us just in a very quick line about what your interest in this topic is, that will be really helpful. In terms of questions, Nellie, how do you want us to manage questions as we're going through the session?
We have a Q&A section right at the end. It's 15 minutes, it says 45 there, but it's 15 minutes. So if we could perhaps save some of our questions, but if they're burning and you want to share them with us through the chat, we'll try to go through them as we speak.
Lovely, thank you. I'll be keeping an eye on the chat as well, so if there's anything that comes up, I'll give you a little flag and say, and draw your attention to it, Nellie. Okay, so without further ado, I'm going to hand over to Kieran.
Thank you, Claire. Can I just get a check on who's moving slides for me, please? Nellie, could you assist?
Yes.
Thank you. Fantastic. Okay, so it's a real pleasure to be here today and have the opportunity to present to you all the work that we've been leading on over the last 12 to 18 months, which has been the phase 1 for the MECC for Mental Health programme, and it's been a really exciting 18 months in that we've achieved so much, and really delighted to present to you today an overview of the project and what we actually delivered and achieved. To give you hopefully a taster of the training content, the materials and the resources that have been created and co-created with our community of practice, and it's been really invaluable in having an independent evaluation to support the significance of this work, and we will be presenting to you our evaluation findings. Thanks, Nellie. So first of all, A bit of background into the Royal Society for Public Health. So we've been in a long-standing relationship with Health Education England for a number of years as a public health charity, and delivered lots of programmes of work in the kind of the mental health sphere really, and now we're really recognised as kind of a strong player in that field. We are an independent public health education charity. And we've been long-standing for over 100 years, and the organisation has many assets and many divisions, and the division that I lead on with the team, with Nellie and Sam, has been around designing and delivering national and regional programmes. And so back in January 2020, we were commissioned by Health Education England to lead on the MECC for Mental Health project. And the overarching aims really were to upskill the non-specialist workforce in primary and community care settings across the north of England. So this was a real regional approach. And by doing this, we were able to supply high quality evidence-based training that has actually developed knowledge, skills and confidence to really integrate mental health and wellbeing in conversations, in everyday practice. And we delivered this programme from March 2020, and we've just completed that in terms of launching our independent evaluation report earlier on in the week. So what is MECC for Mental Health? The Making Every Contact Count approach aims to use the millions of day-to-day interactions that healthcare and the wider workforce have with individuals to really actively engage them in conversations about making positive changes for their mental health and well-being. It's a really well-established evidence-based approach, and those discussions that often take place are defined as very brief interventions, and they can typically last no longer than 3 minutes. And as a result of that, we saw an opportune moment to look at, well, actually, if those everyday interactions are taking place through healthy conversations, how do we take that approach and embed the mental health concept within it? So in the very beginning, early phases of March 2020 through till about June or July, we were developing the concept for a mental health project model. And this is presented before you. And what we actually did was we thought about the approach that we needed to take, not only to upskill and cascade the approach across those particular workforces, but to look at how this could be sustained in the longer term. And so what we initially did was we developed a multidisciplinary expert reference group, and that was including people with lived experience on accessing mental health services and support, as well as specialist, non-specialist workforces, and looking at our cohort of trainers. And as a result of that, we were really able to get into kind of a design phase of all of the training materials and start to talk collectively about how we were going to be rolling out the training. We then led on a lot of stakeholder mapping and engagement, identifying the professions we wanted to engage with and looking more broadly at the settings and services in which this programme of work would be delivered. And we were really, it was really kind of, it came to our attention that there were also a plethora of kind of MECC programmes out there in the domain of developing the wider workforce and other mental health programmes. And it was really important that we kind of assessed the suite of existing provision out there and look to see how we could embed that as part of our model and our approach. And we also embedded the COM-B model, which was the model that we've used to evaluate the change that we've made across the programme over the last 18 months. During then the phases of kind of late 2020 taking us right into 2021, we indeed, of course, had the challenges of the pandemic as well, but that was really within the crux of the time frame where we were going out to recruitment and looking at our lead trainers. And we really had to do this in more than one way, given that we were so limited going out there talking to people face to face. So this is really where we turned kind of to our digital platforms and went out to recruit our trainers and our lead trainers and speaking to them with the opportunity to develop and deliver the training going forward. And then we were able to really have strong engagement throughout that time frame and that process, and looked at our training and pilot areas, and we were able to work with our community of practice to then refine the programme of work, and we'll hear a little bit more about that in a little while. And then we've been really lucky to work with both Lucy and Jo, who are our independent health psychologists, who have helped us to identify through the evaluation processes the changes that we have seen in practice and the changes across organisations in terms of not only leadership but also cultural change, where mental health has been now addressed and embedded as a key component for workforce development.
Thank you, Kieran.
Thank you.
I will then proceed to share with you some of the main outputs from this work. So as a result of all the work that Kieran has just described, we were able to develop an evidence-based and corporate use training programme. And as you know, we utilised heavily the expert reference group that included lived experience as part of the development of the training programme, and the community of practice that was developed through the engagement with potential trainers and lead trainers. We were able to upskill 12 local lead trainers and trainers from 100 trainers from 83 organisations across primary and community care and other support services as well. The target was to recruit 84 trainers, but the demand was such that we needed to extend. We had to extend the project a little bit more to cover some areas where there was need. The 67% of those trainers who engaged with us delivered training to about 1,086 end users. And this was an amazing achievement because, as you know, we had the pandemic, and the health service was very pushed for time and for capacity at the time. So the fact that these individuals were able to deliver the training program was an amazing achievement, and very true testimony to their support and what they thought it was so important in terms of delivering mental health capabilities and capacity within their organizations and networks. The settings that were recipients of the training program included dental practices, GP practices, social prescribing, pharmacy, and I'll show you another slide where I give you a bit more detail in terms of the percentages and the spread. We also were able to do a adaptation of the core training program to be delivered in cancer care pathways, and we were able to pilot it as well. GM Cancer Alliance was very pivotal to this work, and we were very proud to see that happened, and there is now plans for a bigger rollout of the training program with cancer care coordinators. And we also provided for the development of a MECC for menopause module, sorry. And this was also part of some of the comments and the ideas that came out from the community of practice around linking menopause to mental health and applying the making every contact count approach to it. The end users came from all the integrated care systems across the project area. The highest take-up was in North Cumbria and the North East with 25%, followed by Greater Manchester with 14%, Cheshire and Merseyside 14%, and Humber and Cosvale 14%. And as you see here, 20% of all the training was delivered in dental practices, and we have seen really good outcomes from that work. We have some anecdotal experiences, and Dawn may be able to share a little bit more about that. People are saying to us that they have seen people in their dental practices asking them about their mental health in a very consistent way, which is great. We also had a lot of engagement from social prescribing, and from organisations delivering commissioned work from the NHS in communities. And for instance, we had 13% from organisations working with community health champions as well as volunteers, and from the health and social care sector as well. And we can see as well that there is now some interest being raised in many of the sectors, for instance, in sports and fitness and cancer and social prescribing across the north. We've seen a lot of interest and need for upskilling their workforces as a result of this rollout. I will hand over now to Dawn, who's going to give you a little bit of a taster of the training program, so you can see firsthand what's this all about.
Afternoon, everyone. Great to be here with you all. So yeah, I'm Dawn. I was one of the lead trainer developers on the programme, and hopefully just going to give you a bit of a flavour of some of the content that we developed. Are you doing slides still, Nelly? Yeah, so excellent. So we developed 3 modules, and we were quite specific in terms of wanting to not create something that was unaccessible or inaccessible for people. So each module was developed to be around 3 hours long. Each module is accompanied by a 30-minute online training option. And also the images that you can see on this slide are the journals that we created for each of the modules as well. So the training, or the train the trainer, and then the cascading of the training was created to allow as much flexibility as possible, to recognise that each setting where this training was being delivered would have its own challenges in terms of staff capacity, how much time could be spent with people delivering the training. So we tried to make it as accessible as possible and as flexible as possible. We created some lesson plans that broke down the learning outcomes into kind of, if you are going to chop and change it in quite a big way, then these are the bits that we ask that you keep in as the core messages. So there was consistency and validity in the training, and these are the bits that if you do need to trim it back at all, then perhaps these are the bits that you could leave out. So we'll have a look through each of the modules. So module 1, the main learning outcomes is to identify what is meant by mental health, mental well-being, mental illness. Quite often those terms are interchangeable, so mental health particularly being used when actually we mean mental illness. So thinking about these umbrella terms and how they're used, and looking at some recognised definitions, models, frameworks, and also just defining the MECC approach and explore how this can be applied to health and care settings. So in module 1, just to give you a flavour of some of the content, we go through the dual axis continuum of mental health model, which is the top left. So thinking about the different ways in which mental health can impact on us, both positively and when we experience mental illness, thinking about those 2 different axes. We look at the stress container, which is a lovely way to give us additional language when we talk about mental health. So a lot of the time we struggle to communicate about mental health or mental illness because we don't necessarily have a good language or vocabulary around it. So the stress container introduces the concept of how much stress are we carrying around with us, how do we disperse that stress, what are our helpful coping strategies, and what are the coping strategies that maybe aren't so helpful and that may actually in the longer term have a risk attached to our mental well-being. We look at the place of MECC for mental health in the bigger system, so thinking about in terms of our pyramid of levels of intervention, that actually MECC for mental health is really this population level approach. It's something that in any given setting, we could be thinking about having a conversation with someone about their mental health and well-being. And then giving a framework, we got quite a lot of feedback that actually this was really useful, the 3A's framework, to give a structure to the conversation, even though it's a very short conversation, that people felt more confident when they had a framework. So we used the ask, assist, and then act framework, asking if it's okay to have that conversation with a person, making sure that we have their consent, their agreement to have a conversation. Again, asking permission if we can assist in any way, and then jointly agreeing what actions can be taken. So that's a very obviously brief overview of the framework that we go into much more detail around. Module 2 is more around skills building. And again, when we've got skills, then we can hopefully have increased confidence. And I guess whenever I look at mental health awareness training, I'm thinking my overall outcome is I really want people to go away feeling more confident, to have a better conversation about mental health when we feel we might need to. And helping people, I always describe it like switching on your mental health radar. So, you know, where can we take that opportunity to have a conversation and ask about mental health when we might need to, or when we have the opportunity. So in this section, we look at some of the stigma that exists around mental illness. We look at language and the absolute importance of language when we're talking about mental health, because there's a lot of normalised stigmatising language that we see around mental illness. The newspaper that you can see in the top left, that's actually a genuine newspaper heading that I picked up a while ago. You know, so the ability of the media or public opinion just to focus on the fact that mental illness is associated with threat or fear, and that actually we share the statistics around actually how vulnerable people are who experience mental illness, and that they are always the ones who carry the most risk in terms of being the victim of either abuse or violence or any criminal kind of behaviour around them. We talk about the barriers to accessing support. So what is it that stops us maybe asking for help when we feel that things might not be okay? So we talk quite a bit about self-stigma, about social stigma, self-stigma being why should I ask for help? You know, there's a lot of people worse off than me. That can sometimes be an element of self-stigma. Perhaps it's a case of not thinking that anyone could really help, that things are not solvable. And then social stigma, you know, what will my friends or family say if I say that I've been to get some support for my mental health? Fear of the unknown we talk about. So actually what's going to happen to me? You know, what's going to be the impact of speaking out, and what might that, how might that impact on me? And also potentially not wanting to speak to a health professional. So we know that there's a lot of barriers for people in terms of accessing, you know, not wanting to speak to a doctor or accessing health services. Any of you who, you know, work in frontline delivery will know the statistics around female and male accessing any kind of medical support. So that we look at across those kind of conversations. The language matters. Obviously, I've spoken about language with the newspaper kind of heading illustration, but also we don't tend to have a lot of language around positive mental well-being. So actually speaking about recovery is really important. That the data tells us that recovering from mental illness or periods of low levels of mental well-being is likely improbable for the majority of our population. But how often do we actually talk about recovery? How do we support people who are recovering? If someone breaks their leg, you know, we don't sort of tell them to throw away the crutches and get on with it and you know, just deal with things. So how do we create a better language around positive mental health and bring in some of these concepts of thinking about well-being and recovery as part of the mental health continuum? And then we have a think about language again, in terms of how do we speak to people, how do we connect with people. I should say that I led on the mental health kind of area of work, and I had a fantastic colleague, Karen, who was the other tutor developer, who's got a wealth of experience with the MECC process, and she was really keen to build in a lot of language practice and skills building around how we have these discussions with people from her kind of MECC background. So, you know, a brilliant input from her as across the project as well. And then module 3, we looked at developing the awareness of what's available locally to support services and how effective signposting can be put in place, and developing people's confidence to look at signposting pathways and building those means of helping people connect to support that they might need at the right time. Again, just a flavour of the content here. So we looked at some case studies, thinking about how we could have a conversation with people when we might need to, a lot of skill building around this again. We introduced MECC Link in some areas, so it's a regional resource that lists what help and support is available. Different levels of the amount of information in different areas, but it's worth checking out for definite as a point of reference for signposting. We talk quite a lot about what we mean by mental health literacy, the ability to access, understand and use information around mental health, and again skill building to have better, more confident conversations about mental health. And again, just a little kind of framework to give people around check, chunk, check. So it's linked to the 3 A's. It's a different way to think about have people understood the conversation that we've had. And Karen was really keen that we build in an appropriate way to check, because if we just use the closed question and say, are you happy with everything that we've discussed today? And someone just says yes, we don't really know whether that information that we've provided has been taken in. So check, chunk, check gives us a way of saying, you know, can I just check back and make sure that you've understood what we've talked about, and then, you know, are you feeling confident about accessing the support that we've talked about, or is there anything that I can do to further support you? So I'm hoping that that's given a bit of a flavour of the 3 modules. As I say, each module comes with a journal that the learner works through. It's got different activities, so it's quite engaging. It's also got, at the end, it's got a reflective practice for people, because what we know is if we're supporting other people with their mental health, then we need to really be proactive at looking after our mental health as well. So we introduced that concept of self-care as a helping professional, which many of these frontline staff that we're trained will be. And the online 30 minutes of training that's been developed as well is really, you know, really interactive, really good to pull out the key messages from each of the modules. So I hope that's given an overview, and if there's any, I don't think I've seen any questions come in on the chat, but happy to pick up any as they come in.
Thank you, Dawn. That's great. And this is just an image of where the training program materials are being held, and anyone who's in the Making Every Content Count a community of practice has access to all of the materials here, which includes the e-learning, the training materials, case studies is delivered and developed by other trainers, and an opportunity to share as well questions and answers as well. I will hand over to Lucy for the evaluation element.
Okay, good afternoon everyone. Thanks very much, Nellie. So my name's Lucy Byrne-Davis, and I am one of the independent evaluators of the MECC for Mental Health programme. And I'd like to just introduce a little bit about the type of evaluation that we conducted. So many of you will be familiar with an outcome evaluation or a process evaluation, and an outcome evaluation really answers the question of, does this thing work? And a process evaluation will answer the question of, how does it work, or how does it not work? So we try to do both of those things within our evaluation of this programme. As was mentioned earlier on, we framed our evaluation around current best behavioural theories related to how people practice, how health professionals practice, and this can be summarised using the COM-B framework. And I know that many of you on the call are familiar with the COM-B framework, but just to say that the C stands for capability, the O for opportunity, and the M for motivation, and the B stands for behaviour. So really what we're saying is that the influences on people's practice, which is a selection of behaviours, can be summarised under those three of capability, opportunity, motivation. So people need those things in order to be able to practice in a particular way. So the first thing that we did was we worked with RSPH and the stakeholders to develop a theory of change. And so a theory of change just sets out what your issues are, what you expect your programme to change, what the course is expected to change, and those changes are at different levels. So it's what you expect it to change in terms of how people practice, but it's also what you expect it to change in terms of how people think about practice. And Dawn mentioned some really important things there around people's confidence to have these kinds of conversations. And during that theory of change, the stakeholders highlighted two key behaviours. One was having conversations about mental health and wellbeing, and the other was referring people onward for further support if it was appropriate. And so we framed a lot of the quantitative evaluation around those two key behaviours. It's also important in a distributed programme like this one that we know if the training is the same or has some key features. So not that the content's necessarily the same, because as we've heard, it's very flexible in terms of the content, but that the trainers are training in a way that is considered to be important by people like Dawn and Karen, who really understand education and training of health professionals very well. And so we also looked at what we would call training fidelity, so markers that our trainers were training participants in a way that is commensurate with the whole programme and how it intends people to train. So I've said that the key behaviours we looked at were having conversations and were referring for more support. I think we can have the next slide now, Nellie. Thank you. So our key findings. So I think just to mention the baseline to begin with. So we assessed a lot of these factors before people were trained. So it was when they had come for training, but before they'd been trained. And it's important to say that if we think about those two key behaviours of having conversations and referring for support, that there were a large proportion of people who came for training that were already doing both of those behaviours, particularly the having conversations. But then there was this large spread of people who were not taking up many or most of the opportunities to have those conversations. So they were recognising that people could benefit from a healthy conversation about their mental health, but they weren't taking those opportunities. And when we looked at the capability, opportunity and motivation to do those behaviours at that baseline level, you could see that some of those were lower than they could be. And so therefore that gave a very strong indication that the programme, which aimed to develop capability, opportunity and motivation to do those behaviours, would have some ability to change things because the baseline was already down. The referrals for support, that was lower, and it actually remained lower, although it did shift as well. So what we actually saw post-course were statistically significant increases in capability, opportunity, motivation for both of these two key behaviours, for having mental health conversations with people and to referring for more support. We also saw people's intention or expectation that they would have those conversations rising immediately post-course. So that's kind of like a summary, if you like, of whether somebody thinks that they now can go back into practice and or that they will go back into practice and do those things. When we then followed people up, it was a smaller follow-up number that we were able to follow up with the quantitative evaluation. But when we did follow people up, many people, the majority of people did report doing some of those really key things, like avoiding stigmatizing language, doing signposting, asking open questions, and so on. We also found that fidelity was high, so that the trainers were delivering the training as desired, as kind of meant. We also conducted 30 interviews. This was with employers, lead trainers and trainers, both before and after the training. And this qualitative interview really gelled with the quantitative findings that we're talking about here. The quality of training was seen to be high, that it was seen to be filling a gap that people needed, and they had some good recommendations for embedding MECC further, and some recommendations for how to spread this kind of good practice elsewhere. If we just move on to the next slide, Nellie. So just to give you an idea of the kinds of changes that we're talking about, I don't know how familiar people will be with these box plots on the right hand side there, but what we've got is a percentage of people who we asked the question, how many people did you see in the last 2 weeks who you think could have benefited for a conversation about mental health? And then we said, how many of them did you have a conversation about mental health? And we did that before the training and at follow-up. So the first blue bar shows before training, and the second blue bar shows after training. And so you can see this big uplift in the number of healthy conversations people are having with people who they think could benefit from a healthy conversation. The median percentage is that thick black line, and you can see that jumps right up to the top of that bar there. So we're seeing quite a significant shift in terms of the numbers of conversations people are having. Then the second two bars is the same, but about referrals for support. So referrals for support were lower at baseline, and they remain lower, but that's probably appropriate because we don't think that you should be referring everybody for support, but there is some movement in terms of people feeling as though they can refer people onwards as well. And then there are some quotes there. We've got hundreds of quotes. And one of the key things that came out was actually about the flexibility of the approach. So I think people have mentioned that before, that the approach was that you take these 3 modules and then you tailor them to the situation and the context in which you're training. What came out very strongly through the interviews was that was really important to people, that it wasn't an off-the-shelf deliver it in this way, in this time frame. So people felt able to take it, make it their own, fit it into where they could fit it into, and they particularly commended RSPH's support to do that. So having that sort of central function that was able to support that tailoring seemed to be very important. One other thing worth mentioning, which I know that we've all experienced since the big shift online, is that there was some debate, I suppose, or lack of consensus about whether the training was better online or face-to-face. So there was a lot of people who said that they would prefer face-to-face training, and then there were a lot of people who were saying that the online training actually made it much more accessible and much more feasible in their particular context. And so continuing with that flexibility around online or face-to-face is probably also really important as well. I'm here for any questions, and there's much more detail in the report, but I hope that's given you a flavour of what we found.
Thank you, Lucy. Kieran, would you like to wrap up with the learnings, and then we'll take questions?
Thank you, Nelly. Thank you. And thanks for that comprehensive explanation, Lucy. That's been really useful. So what have been the learnings from the overarching programme, and where do we see kind of more opportunities for growth? And I guess we can pick some of that up in the Q&A. So although the project was aimed originally at the primary and community care organisations, once this type of work gets underway, you automatically start to determine where there are other interest areas and where there's high level of demand, and we've definitely been able to record and document that as part of our core delivery of this programme, and we've identified additional need and demand not only across secondary care and tertiary care services, but also within the voluntary and community sector as well. And it's really those kind of grassroots heart of the community organisations that are requiring the level of skill and expertise to enable them to then take their kind of everyday interactions to the next level in terms of incorporating mental health. We have recommended, as a result of the additional demand and also the additional interest, that further adaptations are considered and developed so that health promotion messages are embedded in clinical conversations across the health and the social care system. The evaluation results have indicated, as Lucy has just articulated, that trainers and our end users have benefited from the adaptability of the training programme, which means that it could be tailored to different audiences, quite specific audiences. And we know that kind of a combined approach in terms of face-to-face and or online learning is deemed most favourable. Similar projects should be considered in terms of building on the experience of this particular core programme, and by developing supportive and flexible ways, I guess, of delivering training on key topics to workforces with different training needs. So an example of that has been our cancer pathways, our stroke and menopause pathways. And online learning was an effective way of delivering training, but obviously, as I've just said, face-to-face is still that preferred option by both the trainers and the trainees themselves. So they've been our main overarching learnings that we've captured.